Epic reports more than 28,000 nursing hours saved. Another Epic hosted implementation followed roughly 5,000 additional nodules. Penny cut submission time 42%. Emmie was linked to 58% fewer billing messages. Important operational signals, but not proof of clinical correctness, follow-up ownership, or what happens when the system is wrong. I have worked both sides, bedside workflow and the clinical informatics implementation meeting. Here is the map: ART for clinician work, Penny for operations, and Emmie for patient workflows. ART is Epic's clinician-facing AI family. It drafts documentation, summarizes charts, and surfaces information that might otherwise remain buried in free text. At UNC Health, Epic says nurses generated more than 1 million AI-drafted end-of-shift notes, completed them over 55% faster, and saved more than 28,000 hours. That is substantial workflow evidence. Public methods still do not establish independent accuracy or safety. The useful chain is encounter, ART, clinician review, then action. A draft is not the outcome. The outcome is a corrected, accepted, or escalated action inside a workflow with a named owner. The more revealing example comes from the Christ Hospital. An Epic-hosted implementation report says nurse navigators followed roughly 5,000 additional nodules, detected 116 additional cancers, and moved 64 patients into treatment. Those figures describe the overall program, not the model's sensitivity, and full public methods remain limited. The model surfaced candidate findings. Nurses verified radiology impressions, created discrete records, contacted patients and clinicians, and closed the loop. Reprocessing historical scans also created more than 2,000 backlog findings. Extraction without ownership can create a better organized safety gap. The model surfaced a candidate. Nurses turned it into a program. That is the pattern worth watching. Draft, summarize, surface, route, and keep the human owner visible. Time saved is not enough. Separate stylistic edits from clinically meaningful corrections. Define ownership for every surfaced finding. Route low confidence, ambiguity, and safety concerns outside automation. Penny supports prior authorization, coding, denial management, and appeals. It is less photogenic than ambient charting and just as operationally consequential. At Summit Health, Epic says Penny cut medication prior authorization submission time by 42%, measured administrative submission time. Not publicly established, approval rate or end-to-end time to therapy. Epic also says 92% of generated responses were accepted without edits. Acceptance is not clinical validity. 92% accepted without edits does not mean 92% clinically correct. Sites still need edit, exception, payer response, turnaround, rework, and therapy start data. Epic reports fewer coding denials among health systems most actively using Penny. That phrase carries the denominator problem. Epic also describes future autonomous coding and appeals. Will means roadmap, not universal operation today. Emmie is Epic's patient-facing AI. Depending on the local build, it can answer chart context questions, support billing, assist scheduling, or send care plan reminders. At Rush, Epic reports a sustained 58% reduction in billing-related customer service messages. That is a message volume signal, not proof of resolution, safety, or patient comprehension. Sutter's current FAQ says Emmie is available to all Sutter patients, but that build cannot schedule or cancel appointments, message the care team, diagnose or replace a provider. Sutter says chats are not part of the legal medical record and providers do not see them. Oxner uses Emmie for appointment interactions. Sutter disables them. One product name does not create one permission set. The product is centralized. The risk boundary is local. Measure resolution, escalation, repeat contact, accessibility, record treatment, and safety when patients ask questions outside scope. Agent Factory may matter more than the three names. Epic has announced a platform for agents that reason, decide, and act across workflows. Organizations can add local policies and knowledge bases, and Epic says actions will be traceable. Announced capability is not proof of universal production deployment. HTI 1 creates transparency requirements for certain predictive decision support interventions in certified health IT. It does not place every feature here under one rule. My operating principle is simpler. Clinical system action needs a source, an owner, and an audit trail. Before deploying any of these features, I would ask 5 questions. First, did the tool remove work or move it into review and exception queues? Second, what is the clinically meaningful correction rate? Speed without accuracy is faster cleanup. Third, who owns follow-up when the system surfaces a finding or detects a conflict? Fourth, can we trace source data, generated output, human edits, final action, and approver? Fifth, what happens when confidence is low, policy is ambiguous, or the patient asks something outside scope? Remove or move, meaningful correction, follow-up owner, complete trace, outside scope plan. If those answers are vague, the workflow is not ready because the demo looked good. Across the 3 lanes, ART's strongest signal is workflow and follow-up volume. Its open question is clinical correction and ownership. Penny's signal is submission time reduction. Its gap is approval and time to therapy. Emmie's signal is message or access change. Its boundary is local scope, escalation, and record treatment. Epic's rollout is real, and some reported results are substantial. They are not portable guarantees. The model is not the moat, the workflow is. For nurses, the test is whether the tool gives time back without weakening clinical truth or accountability. Which lane would remove the most friction in your organization? ART notes, Penny prior authorization, or Emmie messages? Keep organization names and patient details out of the comments. This is Signal Rounds. We will keep separating healthcare AI demos from operational reality.